So welcome everyone. I will be starting some of the intros while people are trickling in. Tonight's webinar is, a special one. It's featuring not one, not two, but three expert opinions on the hot topic of the evening, which is eosinophilic esophagitis. My name is Evgenia Pashinsky. I'm one of the gastroenterologists at NYGA who will be your host and moderator. As a reminder, for housekeeping purposes, any questions you guys have, there will be a Q&A after we're done with the full session. And please, any questions you have, put them in the Q&A box as opposed to the chat box. That's the one that I'll be monitoring and answering questions along the way and saving some of the good stuff for our panelists to tackle at the end. And just to start introducing our team, our first speaker is Dr. Steve Namagon, whom I know since medical school, and I'm very proud to call my partner these days. He's a Mount Sinai lifer, much like myself, and currently an assistant clinical professor. He's very involved in the fellowship program and routinely wins Teacher of the Year. Also is an expert at the more complex endoscopic procedures, including endoscopic dilations, which are a pertinent topic for today's talk and today's medical condition we're covering. Our next expert, it's our own Faith Aronowitz, who's one of our GI dietitians at NYGA. She earned her master's in nutrition and exercise physiology from Columbia University, where she also completed her dietetic internship. Faith specializes in the convergence of gastrointestinal health, eating disorders, and sports nutrition, employing a weight-inclusive, non-diet approach to care in her practice. She has experience working both inpatient and outpatient behavioral health populations, and is a great resource for EOE patients in a very supportive way. Last, but certainly not least, is our guest speaker, Dr. Clifford Bassett. He's the founder and medical director of Allergy and Asthma Care of New York and the author of The New Allergy Solution, as well as dozens of scholarly articles and presentations. He's a clinical assistant professor of medicine at NYU and on the teaching faculty at Weill Cornell Medical College. He's featured regularly by national television, radio, and print media outlets, and obviously not new to the spotlight. Dr. Bassett is an expert in seasonal and indoor allergies, sinusitis, allergic skin disorders, and offers a very integrative and whole body approach to allergy prevention and management. He's also very interested and an expert in EOE. So with that intro, just a reminder, guys, Q&A box for questions, and I'm going to give it away to my panelists.
Thank you for that very kind introduction. And thank you to my co-hosts today for joining me. And thanks to everybody in the audience for listening today. So today's topic is eosinophilic esophagitis. And these are some of the things that we'd like to cover today. We'd like to define eosinophilic esophagitis, which I will sometimes abbreviate as EOE, because saying eosinophilic esophagitis over and over again can be a mouthful. We want to review how food allergies lead to the development of EOE. We'd like to explain how a diagnosis of EOE is established. We'll discuss the treatment options for EOE, and then we'll differentiate food allergies from food intolerances, which is very pertinent to this topic. So jumping right into it, how do we define this condition? Well, there are four components to the definition. It's a chronic esophageal disease. It's immune and antigen mediated. It's characterized by these cells called eosinophils, and it's also characterized by certain specific symptoms. So we'll go through these one by one, and I think it'll make a lot of sense. So it's an esophageal disease, so it affects the esophagus, which is the organ that connects your mouth to your stomach. Now, it's important to point out that the esophagus is not just a food pipe. It's actually a living, breathing organ. It has muscles and neurons, and importantly, immune cells. And if we were to sort of dive down into the surface of the esophagus and look at it very, very closely with an electron microscope, we would see something like this. We'd see the lining of the esophagus, which is made of these little hairy looking cells. And just beneath the surface, there are all kinds of immune cells living there and regulating the immune system. And they're releasing all kinds of molecules that stimulate the esophageal function. So in a condition like EOE, an antigen or a food particle that happens to irritate the esophageal lining in this particular person stimulates the activity of white blood cells, which then release molecules and then stimulate the recruitment of another type of white blood cell called an eosinophil. And this cartoon represents the eosinophil. The eosinophils then travel through the bloodstream and into the lining of the esophagus and cause inflammation. So if we were to then to look at the surface of the esophageal wall under the microscope a little bit even more closely, we would see this beautiful sea of purple. And this sea of purple are normal looking esophageal cells. And then in the sea of purple, you see these little red and pink dots. And these are the eosinophils. These are those inflammatory cells that are infiltrating the wall of the esophagus, causing inflammation. And when the esophagus is inflamed, it becomes unhappy and it causes symptoms. So that leads to the clinical presentation of EOE, and which is characterized by things like dysphagia, which is another word for trouble swallowing. And sometimes the trouble swallowing can get so bad that you can get a food impaction, where the food actually can't go down through the esophagus. And this could lead to a lot of chest pain. As you can imagine, it can be very uncomfortable to have your food stuck in your esophagus. It can also lead to GERD-like symptoms or heartburn-like symptoms, which can be refractory to medications and can last for a very long time. And this is a very important point because this can lead to a misdiagnosis if people assume that they just have acid reflux, but it's actually something like eosinophilic esophagitis. Finally, it can also cause abdominal pain. So you can see there's a whole host of symptoms that can be caused by this esophageal inflammation. Just an important point here is that children can often present differently than adults, and kids can have feeding dysfunction, vomiting, abnormal abdominal pain, more commonly than dysphagia and food impactions that are more common in adults. So again, it's an esophageal disease. It's caused by an activation of the immune system by an antigen. It leads to the flocking of these cells called eosinophils to the surface of the esophagus, and that leads to inflammation and symptoms of esophageal dysfunction. So a few words about the epidemiology of EOE. So first of all, this is a relatively new disease. It was first described in the 1990s, but now we know a lot more about it, including what causes it and how it's treated. Importantly, the most common people affected by it are males in their 20s and 30s, but it can affect all comers. And the prevalence seems to be steadily increasing. This is a chart showing the prevalence of EOE and the trends over the past couple of decades all over the world, in the US, in Australia, in Europe. And you can see that all over the world, the numbers are rising. So this disease is here to stay, and it's going to be more and more common. So how do we make the diagnosis? How do we establish that somebody has EOE? Well, it hinges on three factors: clinical suspicion, endoscopy, and histopathology. So clinical suspicion, we already talked about. These are the symptoms that should lead to someone to think, maybe this person has eosinophilic esophagitis. Trouble swallowing, food impactions, chest pain, GERD-like symptoms that just don't get better, or upper abdominal pain. Another important point is that EOE often travels together with other allergic conditions, such as food allergies, environmental allergies, asthma, atopic dermatitis. So, for example, if a young man with asthma and atopic dermatitis comes to their doctor complaining that they have trouble swallowing, a light bulb should go off. This person might have eosinophilic esophagitis, and I might want to refer them for an endoscopy, which is the next step in making the diagnosis. So an endoscopy is a test where a gastroenterologist introduces a small flexible tube called an endoscope with a camera on it down through the mouth into the esophagus and into the stomach. The procedure is done under sedation, so the person doesn't feel, remember, or experience any part of the procedure. And as the gastroenterologist is looking at the esophagus of the patient, they usually see something like this: a wide open tunnel, this beautiful, pale, smooth lining, and these nice blood vessels coursing all around the esophageal lining. So this is a normal esophagus. In someone with EOE, we might see something like this. So this is pretty classic. These are what are called esophageal rings. And you can imagine, so first of all, this looks very different from the normal esophagus. And you can imagine that these rings can make it very difficult for food to go down, leading to trouble swallowing and potentially even food impactions. Another common finding, in addition to these rings, are these little white dots, which are actually deposits of eosinophils on the surface of the esophagus, representing inflammation. And finally, you can have these lines running up and down the esophagus, which we call longitudinal furrows, another sign of esophageal inflammation. So the next step is that the gastroenterologist takes a little forceps and takes a piece of the lining of the esophagus and takes a little biopsy. And this biopsy is sent to a pathologist, and the pathologist looks under the microscope and sees something like this. You've all seen this picture before. You are now all experts. You see these purple cells, which are normal, and these little red cells, and these are the eosinophils. And these cells are abnormal. And the pathologist will literally count the number of eosinophils that he sees, or he or she sees on the screen. And if there are more than 15 eosinophils, that constitutes a diagnosis of eosinophilic esophagitis. So why do we care? Why is this important? Why do we want to make this diagnosis and make it accurately and swiftly? Well, because eosinophilic esophagitis can lead to complications. And we already mentioned that these complications could include esophageal strictures and food impactions. So a normal esophagus exposed to chronic inflammation can lead to a narrowing of the lumen of the esophagus, such that food cannot go down. And then when you try to eat this delicious looking cheeseburger, it'll get stuck. And this is a big problem. An esophageal food impaction is actually a medical emergency, because this cheeseburger sitting in the esophagus for an extended period of time can actually cause necrosis of the wall of the esophagus, or damage to the wall of the esophagus, and in the extreme case can actually cause a tear or a perforation of the esophagus. So we really want to try to manage this disease and manage it effectively and efficiently so that we do not have things like impactions and perforations. And this includes an allergy evaluation, which Dr. Bassett will talk about in more detail, an elimination diet perhaps, which Faith will talk about. And then of course we have medical therapies. And again, the goal of all of these therapies is to decrease esophageal inflammation, thus decreasing or eliminating symptom burden and preventing complications. In terms of medicines, one of the classes of medicines that we often use are proton pump inhibitors. So these are medicines you've probably seen in the pharmacy, like Prevacid, Prilosec, Nexium. There are tons of them on the market. They're all used to treat acid reflux and heartburn most of the time, but because they suppress gastric acid, they decrease the amount of acid your stomach is producing, and that's their main function. However, you get the added benefit that these medicines also are anti-inflammatory. They have anti-inflammatory properties, and that's how they help with eosinophilic esophagitis. An important point is that these medicines are not FDA approved for EOE, and so they are used off-label. However, they do have a decent response rate. Up to 50% of people with EOE will respond and get better on proton pump inhibitors. The next class of medications that we have for EOE are topical corticosteroids. And these are anti-inflammatory medicines that are often used for all kinds of different conditions. And unfortunately, there is no topical steroid that is formulated for EOE at the moment. So we as gastroenterologists and allergists have to borrow from our pulmonology colleagues and use asthma medications. So we can formulate or advise patients how to use their asthma inhalers or other asthma medicines to reach the esophagus instead of the lungs. Now, again, these are not FDA approved for EOE, and so they're used off-label, but they do work pretty well with a response rate of roughly 75%. And now this year, it was a very exciting year for EOE because we now have our first FDA approved treatment for EOE. It's a medicine called dupilumab or Dupixent, which is an immunomodulating medication that Dr. Bassett will discuss in more detail in just a few minutes. And finally, if all else fails and the medications aren't doing it, there are endoscopic therapies that we can offer in EOE. And that includes esophageal dilation. So as we mentioned, EOE can cause stricturing or narrowing of the lumen of the esophagus, thus preventing food from going down. So as gastroenterologists, what we can do is perform an endoscopy and use various tools to stretch these narrowings or these strictures, thereby allowing people to swallow more effectively and prevent food impactions. However, if a food impaction does happen, we can perform food disimpactions, where we go in and with all kinds of tools, including this fishing net, and try to drag out any food that's stuck in the esophagus. So with that, I'm gonna now circle back to Faith to talk about dietary management of EOE, and then I'll talk to you guys again during the Q&A.
Okay, so there are a couple of different approaches as far as elimination diets for EOE goes. And tonight I'm going to cover the empiric elimination diet, which is what we use in our practice. But there's also another approach, which is a more targeted elimination diet based on various allergy testing. And Dr. Bassett will speak more to this in just a couple of minutes. So the empiric elimination diet means that the word empiric, rather, means that the foods that are excluded from the diet are based on observation or a clinical hypothesis versus actual testing results or other data. So the 6-food elimination diet excludes the 6 foods that are most commonly associated with food allergies. And those 6 foods are milk, wheat, egg, soy, peanuts and tree nuts, and fish and seafood. And studies which trialed the 6-food elimination diet in adults with EOE showed very promising results in symptom improvement, while also helping clinicians to identify specific food triggers for these symptoms. And so there are a range of options available that have developed out of the 6-food elimination diet. As you can see here on the slide, there's the 4-food, the 2-food, and the 1-food elimination diets as well. These groupings of specific foods are derived from the current literature, which has shown that milk and wheat are the most common food triggers for adults with EOE, followed by egg, soy, peanuts, tree nuts, and fish and seafood. So what does the protocol actually look like for doing one of these elimination diets? So the first phase is the elimination phase, which is 6 weeks of strict exclusion of one or more potential food triggers, right? So that could be 1 food. If you choose the 1-food elimination diet, that could be up to 6 foods if you're going with the 6-food elimination diet. And it's important to note that there's no quote unquote, right way to make this decision of what you're going to choose. Obviously, the 6-food elimination diet is significantly more restrictive than the 1 or 2-food elimination diet. So it's important for the patient to consider what's feasible for them, given their current lifestyle and resources, as well as, of course, recommendations from their team. So once that decision is made, the dietitian will provide extensive education as far as what foods are permitted on the diet, alternatives for excluded foods, tips for understanding how to read food and supplement labels, and individualized meal and snack suggestions according to their lifestyle. So in our practice, we require patients to submit a food log to us for review for the first 7 to 10 days of the diet. And we actually require that 2 times to ensure that the patient is not accidentally consuming any of the excluded foods, right? You wouldn't want to get to week 4 or 5 of the diet and realize you've been consuming that food, accidentally the entire time, or maybe you've been taking some sort of dietary supplement that had the excluded ingredient in it and having to start all over. So that piece is very, very important. And at the end of the elimination phase, the gastroenterologist repeats the endoscopy to assess if the elimination of these foods was effective in reducing inflammation or the eosinophil count. And if that's the case, the patient would then move on to the reintroduction phase, in which they're reintroducing each food 1 at a time for 6 weeks. And in between each reintroduction is a repeat endoscopy generally to determine effectiveness, right? So you're looking to see if the reintroduction of that food has resulted in recurrence of inflammation and a higher eosinophil count. And there's really no set order for the reintroduction phase. It's very much individualized according to each patient's, clinical picture, also taking into account what the patient has missed most from their diet, especially if they did go forward with the 6-food elimination. diet. Maybe they're somebody that really enjoys ice cream, so they're looking to reintroduce milk first. And finally, the last part of the process is the maintenance phase. And in that phase, the identified food trigger or triggers are excluded from the patient's diet long-term. And at that point, we continue working with the patient to ensure overall nutritional adequacy and variety, right? So we're assessing how long-term exclusion of these foods might affect the patient's nutritional status. So, we're continuing to work closely with the patient to provide alternate foods that meet those needs, and potentially looking at dietary supplements as well. So needless to say, the level of commitment required for this protocol is quite significant. So there's a few factors to consider that might help a patient to make the decision that's right for them, whether that's deciding which elimination diet protocol to move forward with, right? Maybe 1 or 2 or 6, or deciding whether any elimination diet is appropriate for them. So some factors to consider include the patient's current nutritional status. So for example, if a patient has poor nutritional status, if they're malnourished, for example, if they have an active eating disorder, an elimination diet might not be clinically appropriate for them. And the patient also has to consider their current lifestyle, right? Do they have a job that requires them to travel 3 to 4 days of the week? Are they on and off planes, in and out of hotels, making kind of consistent meals and snacks difficult? Do they have a special occasion coming up? Do they have a vacation plan that they've had planned for 2 years in advance? All of these things of lifestyle are important considerations. And financial, the patient's access to financial resources. So, accessibility and affordability, for example, of certain meal or snack alternatives, right? This might require the patient to go grocery shopping at a different store or procure foods from a place that might be more expensive than they're used to. Social support is really important, right? This is very much not an easy undertaking. So having people in your corner to support you through the process is quite important. And last but not least, the understanding that multiple endoscopies are generally part of this process, right? So endoscopies don't require the same prep that colonoscopies do, but right, it's still a procedure and something to take into consideration. And with that, I will go ahead and hand things over to Dr. Bassett.
So thanks so much for the wonderful introductions. It's so nice to be with colleagues that really are dedicated and enjoy what they do. You can tell by the speakers tonight, we're all in the same field, so to speak, that we're just trying to identify a problem the patient may have. And in this case with eosinophilic esophagitis, I'm always amazed that I'll see people and perhaps they've had symptoms maybe greater than 10 years, even longer. They may have had familial tendencies to have food issues. I often will say to them, how many glasses of water do you have with your meal? And they say, oh, at least 2 or 3. And I go, how long is that going on? Oh, since I was a teenager. So there are a lot of people that may have food-related reactions, but they don't get the relief because they don't get the diagnosis, because they don't get to the right professionals for this. So this is what I find is exciting. It's a collaboration. In the allergy community, we've been involved with managing food allergies for decades. And we look at elimination diets and strategies to reduce risk. This is a little different. We'll talk tonight a little bit about the role of EOE, and it's part of what we call the allergic march. And I have a diagram that talks about different allergic conditions through life and how EOE comes towards the end of the pattern of different conditions. On this first slide, you can see the perspectives of an allergist and a gastroenterologist in terms of evaluating, diagnosing, and determining whether to do an endoscopy, which will allow them to visualize the esophagus, as well as take biopsies and confirm the diagnosis. As you heard, Stephen had mentioned, 15 eosinophils per high-powered field is a preliminary cutoff for the identification of this condition, eosinophilic esophagitis. As an allergist, we deal with the eosinophil in a variety of conditions, as well as in asthma And one of the new treatments we'll mention tonight, which is dupilumab or Dupixent, has also been used for the past many years in allergic asthma, chronic sinusitis, as well as eczema or atopic dermatitis. So it's exciting to have a potential management tool that is effective in multiple conditions, both allergic conditions and in this case, a gastroenterologic condition. As you see here, I have some pictures of airborne allergies as well as foods. And again, what inspired me is what I just said. It's a special interest. I've been involved since over 10 years now. We've had some papers in the literature, and I'm always amazed that our first paper said, how many years did it take before you actually got a diagnosis? And this is in terms of discussing with our patients in the office. 6 years, 10 years. We have an average of about 6 to 10 years. And that means they've been suffering and suffering. They go to restaurants, they're embarrassed, they can't eat foods. They have to be careful what they eat. And it's amazing how they don't really have the insight. It's not something that people think about. And we're here tonight to educate our patients, but also to educate our colleagues, primary care physicians, emergency room physicians about this unmet need in terms of identifying this condition early on. And I think that's a very important observation. I'm going to move to the next slide. And this is talking a little bit about over the last couple of decades, eosinophilic esophagitis has emerged as one of the leading causes of food impaction. And literally, that's getting the food stuck in the food pipe or the esophagus. In children, it may be less obvious. As Steve mentioned, they may present with heartburn, chest discomfort, or acid reflux. So we see different presenting symptoms in adults and children. We're going to talk a little bit now about the differences between a food intolerance, which is not an allergy nor a food allergy, versus a true food allergy, and just go over some of the terms. And of course, we'll have questions at the end if anyone still has questions about the differences. So a food intolerance is much more common, and it's experienced with typical food-associated symptoms, but it does not involve the immune system. Typical intolerance symptoms are largely gastrointestinal. We'll talk about this a bit now. Gas, distension, bloating, change in stool habits. And one may think of irritable bowel syndrome, which is of the lower GI tract. And they have a lot of similar symptoms in people with IBS, which is a very common condition in children and adults in terms of people with those symptoms. However, now we're talking about food intolerance. So lactose intolerance is a great prototype to start with. It's very prevalent. There's ethnicity depending on where your family is from, and there are different genetics in terms of who in the family or who in your lineage will develop certain deficiencies. The symptoms result from lack of milk enzyme lactase, and thus it does not allow proper digestion of cow's milk products, leading to discomfort. Now, people may find that they can tolerate certain foods, such as, say, Parmesan cheese, which is very low in lactose, but cow's milk, mozzarella cheese, ice cream, that could be a big problem. And so those are intolerance symptoms, and those are very prevalent. And gastroenterologists, when necessary, do have breath tests that they can utilize to characterize, confirm those types of symptoms. Again, the food intolerance takes place in the digestive system. It occurs when you're unable to properly break down the food, simply put. And as you see here, we just mentioned, due to the enzyme deficiencies, we're seeing bloating, gas, abdominal pain, and diarrhea, and so forth. Now we move over to the area which I spend most of my day dealing with is, do you have a food allergy? How do we evaluate it? How do we confirm it? And what's the difference between a sensitivity and a clinical real-world allergy? So a pediatrician can order a blood test for his pediatric patients, and he may say check a variety of patients for, say, peanut allergy. Does the test and says to the mom or the dad, this is a test here, this is a sensitivity. As an allergist working together, what I would see is an opportunity for collaboration. That means the sensitivity exists, but if you don't have symptoms, then you don't have a real-world clinical allergy. And many of our tests do display through blood tests, skin tests, and so forth, a sensitivity to a food, but unless you're having real-world clinical symptoms, that is not a definition of an allergy. Now, I was involved with a study a couple of decades ago that looked at when you ask a consumer in a US household, how likely is it that people in your house, and what percentage of people do you think have food allergies? Usually you get a number like 20 to 30%. When you actually look at it in adults, it's probably more like 1 to 3%. And in children, because of the prevalence of cow's milk allergy in the early years, it may be as high as 6% or so. So food allergies are certainly less common than a food intolerance. And you see here that now we're using the immune system. That's how we control how your body defends itself. So if you have an allergy to cow's milk, your immune system actually sees the cow's milk as an invader or something that's on attack mode. But instead of your immune system being smart, it overreacts, producing Ig antibodies to specific foods. And these antibodies travel to that release chemicals. You've heard of histamine, and there's many other chemicals that are responsible for an allergic type reaction. Unlike an intolerance, again, a food allergy can cause a serious or even life-threatening reaction. And that's why we're trained as allergists to mitigate risk, talk about anaphylaxis, keep people away from the ER, and do everything we can also to keep them prepared. And that would be having, for the appropriate individual, an epinephrine autoinjector pen that is the drug of choice for people with food anaphylaxis. And even in this case, a small amount of a food, by eating it, which is the number one way that people have exposure to foods and then food-related reactions if they are truly sensitive. And then there's contact on trade tables in a plane. People might go on the plane if they have family members with a nut allergy and they'll wipe it down. That's infrequent cause as well as inhalation of the food. We're really talking about ingestion tonight. This is a fairly general talk. So food allergies, again, an immune response leading to a characteristic array of symptoms from mild oral allergy, itchiness of the throat, and so forth. Each transient go away in a few minutes, all the way to multi-organ anaphylaxis that it may involve a variety of different systems, respiratory symptoms, wheezing, shortness of breath, coughing, the throat tightness, the larynx, inflammation, feeling like your throat is closing up, the mouth and face, oral facial swelling in an individual with anaphylaxis, often accompanied by urticaria or hives. So these signify immediate type reactions. And you see here the nuts and shellfish. So the first quiz question, we'll see who gets the score right tonight. What's the number one food allergy in adults in the US? Is it nuts, peanuts, or shellfish? And we'll come back to that in a little bit. So type 1 food allergies usually start within several minutes up to an hour after a food ingestion. And again, as we mentioned, there are skin symptoms, respiratory symptoms, but as you see there, we can have abdominal symptoms, vomiting, diarrhea, and things that can be confusing. And that's why having a board-certified allergist evaluate your family member and go about performing the right studies to identify risk and whether there is a food hypersensitivity reaction that's occurring. EOE is an immune condition, as Stephen said, and it's associated with food and environmental allergies. And we know from several studies, including my colleague's study at the University of Pennsylvania, Dr. Jonathan Spergel, we know that in some of the studies he looked at in pediatrics, there were individuals that may have had a predisposition to have more symptoms, or the diagnosis was picked up during spring and fall when pollen is higher. We definitely see a relationship there in terms of the pollen season and the prevalence of diagnosis of EOE. We're talking about 3 unique dietary eliminations as part of today's management of EOE. And Faith just went through that beautifully and explained some of the basics to understand, and I thought it was really well explained. The elemental formula, we're really not going to talk about that. That's essentially an amino acid formula, which is not something we're going to talk about really at this time. The empiric-based diet, or the food elimination diet, comprises what Faith mentioned to you, 2, 4, and 6 foods. And that's something that individuals will either look at me as an allergist and say, you got anything else? I'm just not going to give up dairy. I'm not going to give up cheese. I'm not going to give up wheat and pizza and so forth. And that sometimes can be a hard sell. Or I have other people that are like, tell me what to do and it's going to get done. We know that the data shows that empiric-based food elimination diets, when we choose dietary therapy, remember, as Steve mentioned, Medical therapy includes acid reflux pills, such as PPIs. And now, of course, we have Dupixent, which we'll talk about in a few minutes, which is the world's first biologic and FDA-sanctioned drug for eosinophilic esophagitis. And finally, we have targeted diet based upon varied allergy tests. And we've been going back and forth over the last couple decades, the utility of allergy testing and taking a diet based upon that. And we almost always will add cow's milk to that diet because of the prevalence of cow's milk in eosinophilic esophagitis. And we have a variety of IgE tests. We have a variety of skin tests and so forth. Now, EOE is highly regarded, related to as an allergy, but it's not thought to have a typical type of food allergy. So it doesn't occur immediately. You're not going to have someone go to the emergency room for having hives and respiratory symptoms. That's with a type 1 food allergy. It appears to be more consistent with a delayed sensitivity that occurs over time. And it may also correlate in many people that have atopic histories or allergic family histories to various foods, as well as pollen and even indoor allergens. What I find here very interesting is the data seems to suggest, when we talk about it in the discussion part, we can go back and forth, that the longer the eosinophilic esophagitis is untreated and the longer the delay, the disease progresses and complications are more likely. And that's the key, is to be educated, be aware of what we're looking for, identify this condition earlier as possible, because there's so many wonderful things we can do to educate, modify, treat. And now we have a new biologic that's designed in many individuals that would be another opportunity to control the disease by controlling the eosinophils. Again, a little bit about testing, oral food challenges, IgE-mediated food testing. That's what I do throughout the day to identify patients who may be at greater risk of acute food reactions. In EOE specifically, one of the other reasons may be if we're going to reintroduce the food back into the diet, we certainly want to have a sense whether there is a true food sensitization or a clinical reaction may occur. The 3 tests that we use are typically skin prick testing. A to B patch testing is very infrequently used. It's more of an investigational tool, and that is basically fresh food put on your back, as much as a patch test would be done for somebody with contact dermatitis or skin allergies, such as checking for fragrance, metal, and other skin allergens. And the food sits for 48 or 72 hours. And of course, IgE blood test, which is the going to the lab and measuring antibodies to specific foods. The data shows it's equivocal. Role of food allergy testing. What is the role of food allergy testing? And at this point in time, most individuals will rely on the empiric diet if we're talking about dietary therapy because of the data, and it does not involve allergy testing. I have many patients that also have a variety of allergic conditions such as asthma, eczema, and things like that. And there may be an overlap. And by understanding where the patient's coming from, the family history, and the overlap, we sometimes can make decisions. Frequently, we will do allergy testing when we suspect a food sensitivity and so forth. But I think it's one of the tools in our toolkit, and we're learning more about elimination diets versus targeted diet, looking at food skin tests and other tests in some individuals where there is a reason to do those tests. Testing for allergic sensitivity to environmental allergens, again, pollen, as you see there, the ragweed pollen, is a very important tool when evaluating a patient with symptoms of seasonal indoor allergies, asthma, and other allergic conditions that travel along with EOE or may travel with EOE. A strong association of eosinophilic esophagitis, again, with food allergies, asthma, and eczema, which is atopic dermatitis. A pattern of newly diagnosed EOE, as I mentioned earlier, may be more likely during peak seasonal pollen time periods and less so during wintertime. Research has also identified between 1/3 and 1/2 of children with seasonal indoor allergies and up to 65% have been estimated to have allergic reactions to food. So there are definitely some overlaps, but the key is the right testing for the right reason for the right patient at the right time is the key. It's not a one test model for everyone. It depends, and there's a role for different types of tests in terms of identifying certain sensitivities. Now, moving over to the last part, which is just very brief here, talking about the FDA has now approved dupilumab, which is a monoclonal antibody, a breakthrough drug, a breakthrough classification for the treatment of eosinophilic esophagitis in adults and children greater than 12 years of age. Dupilumab also improves swallowing, dysphagia, and allowing the food to go down into the esophagus, from the esophagus into the stomach more easily. And it will decrease the number of eosinophils in the esophagus, as well as I mentioned, improve symptoms. Now, we do see individuals on a blood count called the CBC or complete blood count that will have a rise in eosinophils in the blood. And that can be seen in between a third and even 2/3 of individuals with eosinophilic esophagitis. That's another marker. So the biologic would be indicated for an individual that perhaps has tried dietary therapy, or they've tried the inhaled steroid swallow and they didn't tolerate it, or perhaps they've tried the acid suppressive therapy, which is with the proton pump inhibitor. And a decision would be made based upon the patient, his response to any of these treatments, and of course, pre-authorization that sometimes is necessary with the insurer to get an approval for dupilumab. I find in the patients I've used in dupilumab, I've seen robust responses, and I'm excited to have that as another drug in our toolkit to prevent complications and provide options for people that may have had less successful benefit from some of the other modalities we talked about. The modalities between dietary therapy, drug therapy, and when necessary, dilation therapy, those are going to be things that people try and are prescribed by their gastroenterologist and in some cases by their allergist in a collaboration setting. It doesn't work for everyone, and you will find individuals, as we'll talk about maybe in the next 5 or 10 minutes, they try one approach and they can't stay with it. They just can't deal with the elimination diets, but other people may gravitate towards medical management, which is definitely moving in that direction because the medical management is often very successful. And now we have a biologic that will bring in efficacy, safety, from what I understand reading through all the clinical trials, and something new to help individuals who have EOE and have been suffering for a very long time. This is the example of a Dupixent that would be administered as a self-injector at home, and that's actually quite convenient. We already do that when it comes to asthma and other conditions. So that's the end of my talk. Now I believe we're going to have an opportunity to have some questions and answers, clarifications, and the harder the questions, the better. Thank you for allowing me to join with you colleagues tonight on a topic that I think is increasing and something that I think is very important to be aware of.
Thank you, everyone. That was an amazing talk with a lot of information. Gotten a couple of interesting questions. I think there's a little bit of something for everybody. So I think a burning question that sort of came in first was whether untreated EOE can increase the risk of developing esophageal cancer. I think that's a question for the doctors in the room here.
So as far as I know, there is no evidence linking EOE with esophageal cancer. It is true that other inflammatory conditions in the esophagus, such as untreated severe acid reflux, can lead to conditions such as Barrett's esophagus, which then can lead to esophageal cancer. This is not something that we've seen with EOE. Evgenia, do you agree with that?
Yeah, completely. I mean, it's definitely a condition that could be debilitating, could cause a significant amount of complications, but I don't think there's been any links whatsoever that we know of the oncologic variety, which is a good thing. A question for Faith would be, kind of how feasible is this whole sticking to this long-term dietary elimination plan? Have you found success, and have you found patients to be able to adhere to this long-term, or do you find that people end up going on medication?
Yeah, it's a good question. And I think it really depends on the patient. It certainly is manageable and possible if the patient has the right resources. And I think a lot of that also has to do with, the patient making the choice of 6 food, 4 food, 2 food, 1 food, right? Like obviously 1 food is somewhat easier, but then that can prolong the process, right, of sort of working through all of the potential triggers. So it's certainly, I have seen patients stick to it. So it's definitely, it is an option.
I think this is a much more feasible option in pediatrics than in adults. I think if there's a parent controlling what goes into a kid's mouth, they can really effectively use the diet.
I don't know about you, Dr. Namagan, that all really depends on the age of such child, because I can
Right.
control at home all I want, but goes all out the window. So I mean, obviously you have to have, compliant patients, whether they're children or adults, I think.
Yes. Yeah. I think that drives home the point. It's
Yeah. I think a question for the doctors is, among all the different treatments, the medical variety of medications, what are the side effects to such treatments? And sort of, is this a long-term forever, I have to be on medicine situation, or is there a chance that I could one day stop these medications and be okay?
So in terms of the treatments, so PPIs, or proton pump inhibitors, the acid blockers that we use for most commonly for heartburn, they are exceedingly safe medications as a whole. I mean, I can walk into CVS and buy a truckload of Nexium and no one's going to say a word. And that speaks to their safety. They're available over the counter. Having said that, there's no free lunch in this world, and any medicine can have some long-term side effects. And some issues that have come up with PPIs include issues with absorption of certain micronutrients, perhaps increased risk of certain infections. There's also been implications of PPIs causing problems with the kidneys, and the list goes on. But again, these are exceedingly rare side effects. In terms of steroids, so steroids are immunosuppressive, so there is a risk for certain infections. The most common infection that we see in people who are using inhaled, or I should say swallowed, steroids for EOE is fungal infections of the mouth, or oral thrush. It's pretty uncommon if the medicine is used properly, and is easily treated if it does occur. Other infections I think are fairly unusual, since this is a low dose topical treatment. And maybe I'll ask Cliff to comment on his experience with side effects with Dupixent.
It's really well tolerated, and what's nice about it is it's cross-platform. So in dermatology, we've been using it, and dermatologists around the world have been using it significantly, game changer, so to speak. And then, of course, we have other biologics that are involved with clinical trials moving along. Nothing I know of in terms of anything imminent, because we don't know until it's announced. That's the way it works. But certainly we're going to see some other probable players in that field that we use in terms of bringing down the eosinophil counts and so forth. I'd say that it's really exciting when I have a patient with chronic sinusitis, so they may have polyps and they have EOE, or they have eosinophilic asthma and they have EOE, in terms of hitting it with one gun, so to speak, and you've got 2 different conditions that are treated successfully and complementary. So I think that's really exciting. The at-home is very attractive to people. They can learn how to do it just in a few minutes. There's all kinds of people that will come to your house and do training. So I think that biologics is certainly here to stay. Certainly in gastroenterology, it's a huge part of people that practice inflammatory bowel disease and see those patients and so forth. So I think it's a very convenient. None of these are what we call a cure. They're all involved in treating. And in many cases, when we stop a certain modality, whether it be dietary medication, there are times where it appears there is a resolution. The eosinophils go back to normal, the symptoms go away. And in some patients, not the majority, I would say, because it is a chronic condition, they may see, periods of time where they don't have active disease. So that's not something we can predict. but we do see a variety of responses to all of these. And of course, people have opinions, and some people don't really like cutting it back any food group that they love. And other people wouldn't mind using an asthma pump, but now they're swallowing it instead of inhaling it. So I think a lot of this is preference, and I think guidance and education, there's no substitute, which is why this program is so unique. It's complementary between the two specialties. And I think that that's the first step in excellent care is explaining the condition, what's happening, and giving our patients all the information they can utilize to make the right decisions and move forward with hopefully a condition that up until in the last couple of decades was less common, and now it's becoming much more prevalent. I'm writing an article for one of the journals about that, and if you look at some of the incidence of EOE in some studies, they think it may be as high as 1 in every 2,000 individuals, which to me sounds just really utterly surprising. So it is on the rise. There's some talk in the literature about relationship between rising pollen counts in the world with global climate change and the parallel between this condition. I missed my slide somehow, the one which starts out atopic dermatitis, eczema, asthma for young people, food allergies, goes into seasonal indoor allergies, and then at 20 and 30s, lo and behold, eosinophilic esophagitis. And we have a lot of questionnaires sometimes we'll do with our patients, which will give us a little bit more guidance. Particularly maybe a primary care doctor. That's something we can work with on a different level and try and identify people that are at risk who may be on reflux medications and not really getting the diagnosis locked down. Again, as Steve mentioned, complications are not ideal, and we do our very best to educate and let people know about symptoms like dysphagia, food dysphagia, and how something like that can prove dangerous going forward.
Excellent. So this has been, taking me right into another question for Cliff. A lot of excitement on the chat about the whole pollen situation, because I feel like some people are hearing for the first time that pollen could sort of be a trigger. And the question lies around whether taking antihistamines or typical allergy meds would help with this somehow, or prevent some of the seasonal, flare-ups or pollen-related flare-ups, AKA taking whether it be Zyrtec or, Singulair, or some of the things that are used for typical allergy symptoms.
So there's an association with a variety of conditions we talked about. Right now we're going fall into winter. I'm not feeling very seasonal, but there's a seasonality to that. And in the beginning, one of my first papers or second papers, one was the timeliness, how many years it takes to diagnose the EOE. But we looked at what time of the year, and we did see a peak in the spring, particularly during the pollen season. There's definitely an overlap. There's a few studies, they're very small, looking at allergy immunotherapy, which are actually allergy injections that we use for patients who have allergic symptoms, seasonal, indoor, asthma, and so forth. And some studies did show some improvement in the EOE, but these were not big powered studies, and it's very difficult to say. In general, in our allergic individual, we educate them about the pollen calendar, the season, and I pre-medicate or pre-strategize before the season kicks in. We can do an amazing job before the season kicks in if they start to use their medications. So there's definitely an overlap between the season. I know some colleagues, and I've read some review articles talking about using nasal steroids in the spring before the endoscopy and the biopsy, and that may have an impact on the number of eosinophils versus a biopsy that might be done in the winter time when the pollen season, it doesn't exist. So I think there's a lot of questions, a lot of ideas, but I think we're always learning, and this condition is certainly something that is faced with a lot of challenges, and I think we're mastering it to a certain extent than we could have ever imagined just maybe 20 or 30 years ago.
Great. And a question for Dr. Namagon. What are the risks of having an esophageal dilation? Kind of what if somebody has a stricture at the time of diagnosis, has impactions and needs one? What is there to be expected?
Yeah, so that's a great question. And there's been some controversy about this over the past few decades since EOE has become more prevalent. And I think the short answer is that dilations are generally safe in people with eosinophilic esophagitis. Initially we were worried that in an inflamed esophagus, doing a dilation can actually cause a perforation. But in a controlled setting where the dilation is done in a safe and serial manner up to a reasonable size, meaning you don't have to blow the thing open, you just have to make it large enough for the person to be able to swallow comfortably. Dilation can be done very, very safely. So I think that if a patient has a stricture and requires a dilation, they should not hesitate having it done.
One more for Dr. Bassett and Faith a little bit is beyond that 6 food elimination group and sort of the common allergens, has there been any research, looking at any other additional foods or any other additional food triggers? Is there looking to be an individual approach for patients, or are we kind of set with the 6 food groups?
Well, I think that's a great question. I know if you look around the world, there's many different researchers who study in pediatrics and adult medicine, EOE, and you can see legumes, meats, chicken, and a variety of other things are included. And there's a conversation about different age groups and what is really important. So I think there's some discussion. But I do think it's amazing how that empiric diet, although it's just 2, 4, or 6 foods, seems to be the gold standard and seems to be holding up. Different parts of the world, they may have a more Mediterranean diet. They may use more foods, lentils, chickpeas, sesame. So there are different things in different parts of the world. And they may actually go ahead and try and modify some of the elimination diets and also diagnostic testing. I think diagnostic testing definitely has a role in EOE. It's less certain and clear than it would be in somebody presenting with a typical food immediate type reaction. Again, we're talking about maybe the T cell mediated, for the most part, delayed mediated foods, types of sensitivities. So it is different, and I think that we're learning more about it. And I think that's a great question. I don't know, Faith, if you have any questions about. They like to sort of maybe say, well, this food here, I feel there's something there, which is maybe anecdotal, but there is room for modification. The only thing is how many foods they can really avoid in the real world and do it for 6 to 8 weeks. And if they have to have an endoscopy and another evaluation, this can go on for a period of time, which can be very challenging for an individual.
Right. Yeah. There's certainly sort of a diminishing returns, right? There's only so many foods that one can exclude at a time. But those 6 foods are the most common triggers, but each patient can certainly have their own kind of unique set of triggers. And I think, as Dr. Bassett said, we're continuing to learn more about what those could be.
Excellent. And then I think there's a question about, having repeat endoscopies over and over and over. It's a lot of work. It's obviously financially problematic for some patients. It's missed time off of work. Are there any kind of more innovative, non-invasive monitoring strategies that are in the works or that we have available at this point?
So there is something that's either in the works or might be available in some places now. There's something called a cytosponge, which is basically a little dissolvable capsule that's attached to a string. You swallow the capsule, and then the capsule dissolves in your stomach. And because it's attached to a string, the string is coming out of your mouth. I know this sounds very, very appealing. And then pull this little string back so that the sponge that comes out of the capsule scrapes off the lining of the esophagus. And then we pull it out and send it to the laboratory, and they can actually count the number of eosinophils. So this is something that might be available at some very specialized centers, but I don't think it's ready for prime time in the real world quite yet. There are also some places that do unsedated endoscopy, so that to some degree that at least decreases the need for recovery after anesthesia, and perhaps someone could come in, get their endoscopy, and just go back to work. So yeah, there are definitely things on the horizon that could make this easier.
Excellent, guys. I think we covered a lot of questions. I think if anybody has any particular questions for us, feel free to reach out via our portal. This talk has been recorded, so it will be available on our website and on YouTube in the coming weeks for anybody who may have come late or has any family members or friends that could use a little bit of this talk. I want to thank my amazing panelists here, Dr. Namagan, Dr. Bassett, and Faith, for contributing their expertise, and we wish you all a good night.
Thanks, everybody. Good night.
Thanks all. Good night.
Good night.